Morning. So most of you are wondering, what am I doing in a pediatric epilepsy surgery conference? And I'd point out that when my colleagues indicate that there's a 20-year lag between when you first see the patient and consider surgery for that patient, a large part of that lag is actually in the pediatric years. And in my last job at the University of Wisconsin, where I directed both adult and pediatric epilepsy for about 11 years, this problem became very clear to me. In the pediatric age, parents tend to hover and be very cautious, and the last thing that you'd ever want to do is surgery. And you can see the child as they migrate into those teenage years and become 15, 16, 17, taking over from the parent and saying, making a much more definitive thing of, yes, this makes sense. And of course, the adult patients, when you talk about surgery, oftentimes they say they want a date to schedule it rather than have elaborate discussions about the problems with it. Now, I'll show you an old slide because really when we talk about pediatric epilepsy, we're talking about mesial temporal epilepsy in the minority of situations. And if it's temporal lobe epilepsy, it's likely to be neocortical temporal lobe epilepsy more than mesial temporal lobe epilepsy. So this will be, and this is an old slide, but very important to keep in mind, that might be the seizure onset zone. And the zones are, as you can see here, and it's very important to remember that the lesion, the MRI lesion may be in this location right here, and actually the seizure zone is next to it. And this is best illustrated when you have a patient with an encephalomalacia, and there's actually no cerebral tissue in the encephalomalacia. Well, the seizures are clearly not coming from the vacuous zone there. They're coming from the margins of the zone, and that is probably a very important point to keep in mind, and you can clearly see the relationship with eloquent cortex becomes really important. So I will briefly touch, but mostly display these with case examples because I think they really bring forth the case. But remember, frontal lobe epilepsy, oftentimes nocturnal, very brief, hypermotoric, unlike temporal lobe epilepsy, which is hypomotoric oftentimes, and often misidentified as non-epileptic events. They're very refractory, and the semiology depends on which portion of the frontal lobe that they're coming on, and the frontal lobe is so large that the semiology is going to be highly dependent on which portions that they come on. And here is a patient. He is 6 years old, and you can see that classification of seizures in young patients based purely on semiology